Good afternoon and welcome to the panel. In case you are wondering whether you're in the right place or not, we're going to be talking about the use of mHealth technology in the CMS Medicare and Medicaid Innovation Awards. And I'm excited to present this this panel to the conference, and very excited about our speakers, who I'll introduce in just a moment. What I'd like to do is, if we want to get the slides up, please. Thanks. My name is Mark Wynn. I'm a senior advisor at the CMS Innovation Center and actively involved in the Innovation Awards. And what I'd like to do is talk just briefly about the Innovation Center and the Innovation Awards, and then introduce our panel, three of whom have the Innovation Awards, and the fourth one will be talking about how those awards will be evaluated. The purpose of the CMS Innovation Center is to test innovative payment and service delivery models to reduce program expenditures for Medicare, Medicaid, and CHIP, while preserving or enhancing the quality of care furnished. It was set up under the Affordable Care Act and is thus just a bit over a year old, and actively engaged in the process of doing these awards and a number of other exciting projects. The Innovation Awards were created under an open solicitation, which was to identify and test innovative service delivery and payment models that both achieve better health, better care, and lower costs through improvement, and also rapidly train and deploy a new workforce for the changes we expect in healthcare. So the emphasis is not on just the gizmos themselves, but the use of those mHealth technologies to improve health and reduce costs. There's about $900 million in awards, with individual awards that range from $1 to $30 million. The goal of the awards then is to identify and support a broad range of service delivery and payment models to achieve better care, health, and better costs through improvement in communities across the nation. Awardees will be doing a number of different things. They're going to be improving care and lowering costs for the CMS programs, reaching diverse populations, including underserved and remote communities, rapidly improve the proposed model. We don't want anybody who's going to take 3 years of development to get to the end of a 3-year program, and to, as I mentioned, to train workforce needed to run these models. We had a huge response of applicants for these models. About 2,260 applications were scored. We had 190 panels actively involved, and if some of you were involved in those panels, thank you very much. This was a real public service that you performed. The request then was for about $30 billion in awards, and of course it was impossible and really not a good idea to give all those awards. But we looked through these applications with panels of both government and non-governmental reviewers and scored according to the design of the projects, capacity of the management team, workforce goals, budget, and the evaluation and reporting program. We ended up with a portfolio of 107 awards in total, average award size about $8 million, which is pretty significant as these things go. And we estimate that over 3,000 new jobs will be created, and about 70,000 people trained in communities, staff, and in affiliated caregivers. Now, in terms of these awards, we have quite a distribution of funding sizes, but about almost half the awards were under $5 million, with the rest of them relatively small numbers, over $25 million, and the rest in between. In terms of communities, a wide range of communities across the country, urban, rural, suburban, and a good deal in mixed areas, both in entire metropolitan areas and across the states. In terms of population age, a wide variety there too, with focus on adults, elderly, pediatrics, and almost half with mixed populations. Entity types operating the awards, plurality in academic and hospital institutions. Certainly this is where the grant writers are and where you might expect a lot of these, but a wide range of other types of organizations too, including unions, research organizations, psychiatric facilities, home and health, hospice, etc. In terms of the insurance type that the awards will focus on, again, a wide distribution, Medicare, Medicaid, dual eligibles. By mixed, almost all of the mixed organizations have Medicare and Medicaid with a focus, since these are the CMS programs. In terms of the categories of awards, subject categories are widely dispersed, with acute care redesign and high-cost populations taking the largest shares of these awards. What I'd like to do now is introduce the panels before we get into the discussions. First up is going to be Deborah Stewart, who is President and CEO of Affinity Incorporated, which is a leading provider of technology-driven solutions for health, wellness, and financial industries. Under Ms. Stewart's leadership, Affinity has developed a robust closed-loop health and wellness center system that links wellness and disease management programs to over 400 measurement criteria. She has a bachelor's degree in communications and advertising, and also expertise in statistics. Kevin Volpe, next, is founding director of the Center for Health Incentives and Behavioral Economics at the Leonard Davis Institute, which is at the University of Pennsylvania. He's also professor of medicine at the Penn School of Medicine and Health Care Management at the Wharton School. He's a member of the Institute of Medicine. He has an MD degree from the University of Pennsylvania and a PhD from Wharton School. David Goodman will be next. He's co-founder and chief medical officer for First Vitals Health and Wellness. He holds BAS and MAS in bioengineering from University of Pennsylvania and an MD from Harvard and from the Harvard-MIT Division of Health Sciences and Technology. His career has included innovative work on remote monitoring, disease management, drug delivery, and pulse oximetry. Finally, Will Schrank is the director of the Rapid Cycle and Evaluation Group in the CMS Innovation Center. He's going to be leading the innovation efforts for programs supported by the CMS, including this one, that are aimed at reducing costs and improving the quality of care in the U.S. His own research has focused on improving safe, appropriate, and cost-effective use of prescription medications. Will received his MD from Cornell, his MS in Health Sciences from UCLA, Rand, and serves on several national advisory committees for FDA and a number of other organizations. So thank you very much to our panel for coming and sharing with us today. First up, then, Deborah.
Thank you, Mark. Appreciate your opportunity to speak today. I asked my team who's here today whether I should start with a story about Maui or Hansel and Gretel. And so we're going to start with Hansel and Gretel because it's shorter. So when Hansel and Gretel went into the forest, they didn't know where they were going. And they had a hard time understanding where they were going or what they were doing, but they had the right idea. They dropped little breadcrumbs along the way. The problem was that the medium was wrong. The birds came and picked up all the little breadcrumbs, and then they were lost, and poor Hansel had lots of therapy he had to go through and a deep fear of ovens the rest of his life. So what we're going to do today is learn about breadcrumbs and the importance of leaving breadcrumbs along the way with the data that you analyze. And that's what our project is all about. The Everybody Get Healthy project that we're working on is a closed-loop technology platform and a discipline. We've been using it successfully in the financial institutions side for the last 10 years. We've worked with clients like American Express and Charles Schwab, creating closed-loop technology platforms for them that measure over 400 different behavioral criteria. It's the first time we've applied it to the health industry with payers in the commercial marketplace 3 years ago, and we've had tremendous success with it. And now we're getting the opportunity to provide it for the Medicaid population, for 168,000 low-income Medicaid population in Philadelphia. There are 6 integrated factors with this. The closed-loop technology, the health intelligence profiles, we work with CO Inspire, renamed CO Health Analytics, to do all the health analytics for us. A targeted engagement, rewards, and communications across the healthcare chain, with everyone having their own independent portals. Behavior-based wellness programs, one-to-one life tracks, and integrated support technology with a peer mentor program that is being developed by Duke University. The way that this works, if I can make the arrow work, here we go, is we take 5 different sources of data. We take biometric data, that's what my body is telling about me. We do that at the work site, clinic, offices, and health fairs. We take behavioral data. We have over 200 independent data sets that we're using in the behavioral data. That's what the actions that you do say about you. That includes claims data primarily. We're taking the claims data on a monthly basis from health partners and uploading all of the health analytics and applying 6 different algorithms to the health claims to be able to find out what life track to put the individuals on. Provider data, user interface and encounter data, device tracking, predefined success criteria, actions, and just as important, non-actions. So every action or non-action is recorded into the health profiles. The health profiles then link to the one-to-one life tracks, which push all of the next encounters to the individuals. We take also observational data, what others say about you. We have over 100 different data set in the observational data. That includes MTM data, peer mentor data, community health worker data, coaches, DM, caseworkers, and others. Self-reported data, we'll show you some of the really cool mobile apps for all the self-reported data that we're working, and also inferential data. That's all of the demographic data that we've accumulated about the populations. Okay, so let's see how it all works. First, the life tracks are determined, predetermined by gathering 3 years' worth of claims data. So we took 3 years' worth of claim data, did the analytics on the population, and we have set 7 different life tracks for the Health Partners members. Healthy parents, these are a lot of young people with children. You know, we call them kids with kids. So this, again, is a low-income demographic. It's 68% African American, it's 13% Hispanic. So we have a healthy parents life track, teaching parents how to be good parents. We have a diabetic population that's pretty large, almost 30,000 diabetics. So we have a diabetic life track. We have a healthy heart life track, a healthy under 40, a healthy over 40, a weight loss, a tobacco cessation life track, and an asthma life track. So those life tracks are all generic life tracks that will evolve one-to-one based on the behaviors. So basically what we do is they're placed from the claims analytics onto a specific life track. You may be on the diabetic life track. And then the diabetic life track will suggest the first engagement encounter, specific rewards that are tied directly to different outcomes that we want you to be able to achieve. And it will also suggest the first activity. So it suggests those activities in multiple mediums. And this is all accomplished through an integrated technologies platform that is medium neutral. We never do one campaign. For example, we just did the pilot campaign with health partners in the last, 2 weeks, Alexandra? And it's going on right now. We used 5 different mediums for the diabetics. So we not only pushed an Autobot call that called a certain random number of the diabetics. We also pushed a text email campaign. We posted it to the member portal, and we also did peer mentor phone calls and disease management phone calls. So we're testing all different mediums at the same time, going to different segments of that targeted life track population. And then we're gathering all the information about whether they engage or we didn't engage. So far we've beat all of the goals that we had for engagement. So, and we're then using all of that information to inform back the information on the population as a whole and as the individual. So in summary, we take the data that we gather, we create a health intelligence profile. The health intelligence profile then recommends the analytics and the activities and the suggested rewards and the suggested communications. And then we create one-to-one life tracks that are individual and personalized for each individual. And that's and then that's disseminated in multiple mediums. We record the preferred mediums, and then that becomes the #1 medium that we will go out to the next time. The life tracks, let's just show you what this kind of stuff looks like. This is a member web page. You can see here that we do everything in object orientation, and then we code it for which mediums that it's going to. So we break things into groups, elements, units. And so, for example, the right-hand side of the screen is also a cell phone little self-reporting app, but it also appears on your web page. It suggests the next activity. We break things into challenges so that they're 21-day challenges. We found that extremely successful. We're getting 68% participation in the challenges, and we'll show you the results in just a second. This is one of the challenges for the diabetics. We're starting with a drink water challenge for 21 days to stop drinking everything except for water. We'll show you the mobile phone apps for this in just a second. You can see that this goes out in multiple mediums when they get their rewards. We text message them. We collect their preferred medium for them right up front. The peer mentors call them all and get their preferred mediums. But we don't believe what they say. We believe what they do. So a lot of times they'll say the best way to contact me is through a phone. But if they react to the text message, then we're going to send it to them in a text message, not just by what they tell us, but what they actually do. This is all behavior-based. So self-reporting mechanisms. One thing we found early on is that health risk assessments, people lied in that payer space. They didn't tell the truth with them. And that you had to bribe people with a whole lot of money to get them completed. Health scans on the other side, on the commercial side, the health scans, we're getting 92% of the people that will collect a health scan. So health scans are much shorter. You can complete them in 2 minutes. And the line percentage has gone way, way down. And we've effectively done that with over 300,000 participants. So shorter is better on all of your self-reporting. We try and change one behavior at a time. This is one of our Veg Out apps. This is a game you can play. If you eat your vegetables every day, you collect vegetables and you can splatter them everywhere. You can also talk to other people about vegetables, get recipes, and do all kinds of little fun things with your Veg Out app. Our Step Up challenge, which is another 21-day challenge. We put the weight loss people on the Step Up challenge. They, of course, get the pedometers, and the pedometers read and everything else. But that we find that some people like the ones that automatically read and upload, and some people prefer to enter their steps. You shouldn't just assume that we all use just the little pedometer with the Bluetooth and that's it. Some people prefer to enter, and if they prefer to enter, you let them do that. So we have a challenge that's run very successfully with the Step Up challenge. I'll show you the results in just a second. You'll increase behavior in the commercial marketplace in the workspace by 28% if you give them a physical kit. Physical kits increase participation by 28%. And we've tested that significantly in the commercial marketplace and know that that's a fact that we can rely on. So giving someone physically something to work with, that's why our fresh fruit challenges, we give them a fruit cup to measure. The drink water, we give them a water bottle. Give them something physical to do, and you're going to increase participation significantly. The other thing that we've learned is, and we knew this going in, our director of technology is Justin McCormick, who created the Sim games. So he's a big game technologist, but getting achievements, trophies, rewards, and thank yous. If people do a really great job, if they bring their levels down in their diabetes, on, their H1AC 3, 2, 4, whatever that number is, by less than 7%. I'm not a doctor. There's no MD after my name. I'm a technologist. If they bring their levels down, they can win $50 if it's under 7%. But we also call them and say, great job. You did a great job. That does more in terms of repeating the action of success than just about anything else. So take time to give virtual achievements, rewards, and pats on the back. It's really important. This is one of the new iPad applications we've developed and we're testing right now. This is for all of the peer mentors that we are doing with Duke University. They're playing like a game. Most of the health community workers in the area of Philadelphia, the people really serving the population, the Medicaid population, are also unhealthy, and they're making $12 an hour, and they don't have good communication tools. And so this is a game for them as well. They're able to earn points and win prizes and score things. They can talk to each other. They can talk in the system, and they can have all their scripts there and everything else. So in conclusion, I would say this is way cool. We really enjoy the opportunity to do this, and a year from now, we'll have all kinds of facts for you on the Medicaid success that we're going to have for this award. Thank you.
Thank you. And Kevin, we're going to do questions at the end so we can get through the presentations and then discuss them all together.
Okay. Well, I want to start by thanking CMS for their support of this work. And what I'm going to try to do is tell you a bit about what we've put together. We have a very interesting group of 5 different insurer partners and 1 major health system who are all working together to make this happen. So here's the problem we're trying to solve. This is a famous or infamous graph from a paper that was published in JAMA about 10 years ago. It basically shows that adherence to medications after patients have hospitalizations for heart attacks or acute coronary syndromes is abysmal. So about 50% of them stop taking them within 2 years. And for primary prevention, it's of course much worse. Lest you think that this is old data and we've figured this out, I'm going to present you the results from, this is really the definitive state-of-the-art study. Will Schrank was actually the senior author on this paper. But it was a paper that was published in the New England Journal last fall. And basically this was a collaboration between Harvard and Aetna. And they randomized about 5,000 patients to either get free co-payments for their cardiovascular medicines after a hospitalization for a heart attack or their standard co-payments. And 2 things I want to point out here. One is that the control group adherence rate is obviously really bad. 39% suggests we haven't made a lot of headway in the last 10 years. And making these medicines free helped, but it didn't help that much. The adherence rate there is 45%. So what we've been developing is a concept called automated hovering, and it basically uses a lot of insights from behavioral economics, which is in essence the science of how people are predictably irrational, and it brings that together with a lot of advances in wireless technologies. So in essence, there's at least 3 big reasons why we think this is going to be important. One is that there is a big shift that's underway in shifting from a reactive visit-based model for healthcare delivery to one that focuses more on population-based health improvement. Second is, of course, nobody at this conference needs to be told, there's a big proliferation of social media and wireless devices. And then third is there's been really, I think, an explosion in our understanding of ways in which people are predictably irrational and how insights from behavioral economics can be used in ways that can help improve health behavior. So one of the key issues here is if you think about a health system that's trying to solve this, it really can't be solved with a visit-based model, because even if you're an ill patient who goes to the doctor 20 times a year, each of those visits is only 7 minutes, 10 minutes in front of a doctor, so it doesn't add up to a lot of time. So you need some way of, in essence, hovering over patients. You can't do it with a personnel-based strategy because it's too expensive. So you have to have some way of trying to automate that process using some combination of technology and people. 3 main principles. One is the underlying foundation of behavioral economics, which offers practical insights into health behaviors that previously were unavailable when a lot of previous efforts with disease management and other approaches were put into place. Second is the new technologies, which make engagement with patients easier and more possible than ever before. It also creates the potential of providing a lot of immediate feedback in ways we couldn't do before. And then third, one of the underlying models we developed as part of this grant proposal was the reflection that standard randomized trials, while they do provide gold standard level evidence, are somewhat slow and rigid. Typically, we would randomize people. They would be in this protocol for 3 years, 4 years. We'd wait 3 or 4 years. We'd tell you, did A work better than B? That's all well and good. But really, there's an urgency here in terms of healthcare transformation that doesn't really facilitate. So what we've come up with here is a new model which is going to evolve much more quickly in ways which I'll describe. So in essence what we do is we've built a platform over the past 3 years with NIH support, and we have a lot of different types of home-based or employer-based wireless devices that feed inputs into the platform. Here's some examples of pill caps as well as other kinds of devices, but really the pill caps are the ones that are relevant for this study. So a participant is given a glow cap. These are wireless pill caps where the person doesn't need to have a cell phone, doesn't have a wireless network. They basically just put their medicines in this bottle, and then there's a chip where you open the bottle and it sends a signal to our server. The server then gives people feedback, and it gives them different kinds of feedback. It can give them feedback via text, email, or interactive voice recording, depending on what they choose. And then we can also transfer funds to people electronically. So that's sort of the technological backbone of how the system works. And what this model includes is everyone gets these wireless pill caps. They get them for several different medicines, which I'll talk about in a minute. We have them enlist a family member or friend at the outset who is going to be volunteered as a support person for medication adherence. So once I miss 2 days of my medicine, that person will start getting automated alerts, and that person will be available as a resource to try to help this person. A third is that we do have some personnel involved. Our general sense is that while we don't want to have a high ratio of personnel to patients, it is helpful to have some personnel who can be a resource to patients if they start to fall through the cracks. And then fourth is we use daily lotteries. We've used this in a lot of different other studies for medication adherence and weight loss. It works really well in terms of improving adherence. And then there's the self-service customization element. So quickly, the primary outcomes, vascular events, AMI, stroke, acute coronary syndrome admissions, death, following a similar approach to the AMI-free study. We'll also look at hospitalization rates, repeat or new cardiovascular procedures, and costs. And the model in terms of the testing, this is basically what this looks like. We call this evidence-based evolutionary testing. And the idea here is that we randomize people to an approach. So there's a control group, and then there's an intervention group that starts out in version 1.0, that morphs into 2.0, morphs into 3.0. And the idea here is that any intervention, no matter how well it's designed, can always get better. And what we're doing here is we're taking inputs from lots of work we're doing on the side, some of it as part of this project, some of it reflecting all the other studies we have ongoing. And as we get better at, let's say, running a daily lottery for medication adherence, that will be reflected in version 2.0 and in version 3.0. So we expect this to become progressively better as this goes on, with the goal of having a shared savings model that our insurance partners would deploy at the end of year 3. The glow caps, here's a picture of what they look like. There's basically a little orb that looks like a fried egg that gets plugged in the wall, and that's what transmits the signals. These will be used to measure daily adherence. Aspirin, statins, beta blockers. If they have a stent placed, they'll be given also one for Plavix. They're easy to use. That's really the key here. In terms of the different components, the engagement incentives I mentioned, these are what we call daily regret lotteries. People have a high probability of a small reward, a low probability of a big reward. These run every day. You're only eligible to win if you're adherent. You're also told you would have won yesterday if you had been adherent. So the idea is there's a lot of ongoing feedback here, which reflects the fact that people need to take these medicines every day. In terms of the family member or friend, this is related to work that our group and other groups have done in terms of peer mentoring and social incentives and various other kinds of social support. That's obviously a wonderful way to tap into social altruism. There's a lot of it out there. We need to just figure out how to create mechanisms to use that. And it's a way for, let's say you have an adult child. They don't have to call you on the phone every day and say, did you take your medicine today? Did you take your medicine today? You can see how every day that could get really annoying really quickly to both of you. But here we have a mechanism for you to get these reports, and you just get alerted when people start missing their medicines, and then every week you get a report telling you how many of the days they took their medicine. In terms of the engagement advisors, the idea here is that they will help with the transition from hospital to home. They will get alerts once the patient starts missing the doses. And the idea is they really only get involved here if the patient incentives, the social support, it doesn't prove sufficient, and so it becomes a more cost-effective model than it would be if they were really on the forefront. We're also expecting they're not providing really direct support. They're really providing resources and connectivity with a lot of the resources the insurance companies and the pharmacy benefits managers already provide, but which patients may not know about. Then finally, in terms of self-service customization, the idea here is to try to give a set of choices to people to set this up in a way that will make it more likely for them to be successful. We ask people how they want to be reminded. We ask them what sort of person they want to have as their social support person. It can be a spouse, it can be a friend, it can be an adult child. There's also a lot of unexpressed but revealed patient needs, which will have merged during version 1.0. That will be incorporated in version 2.0. We'll segment the patient population. We'll customize the treatments as best we can based on what appears to be most successful for that patient's peer group. And then, of course, as I mentioned, we'll increase the support intensity for those patients who are struggling more with non-adherence. So the goal here is, as we think about healthcare delivery in the future, which will hopefully become much more of a proactive, non-visit-based model, is that approaches like this will provide a way to provide automated inputs to healthcare providers on patient healthcare behaviors at home, automated feedback to patients, and use these type of behavioral economic engagement strategies to get patients to do this at high rates. This is going to be really important if we think about health financing and how that will work in terms of risk-bearing for populations. And we think a key piece is really figuring out how to do this, how to test this, and how to do this in a way that's going to be cost-effective enough that it will be scalable and the insurers will want to do it themselves. A lot of people involved. I'm not going to go into this in detail. I will mention that our 5 insurance partners are Aetna, Horizon Blue Cross Blue Shield, Independence Blue Cross, Health First, and Keystone Mercy. So it's a mixture of Medicaid providers and larger insurers that have both commercial and Medicare patients. We have an advisory board which consists of leading people from each of those companies. They tend to be the chief medical officers of the insurance companies. But it's been a wonderful collaboration. We're very excited about this. We're looking to start enrolling sometime in January, so we're getting pretty close to being able to launch this and really get moving on what we think will be an exciting initiative. Thanks.
Hi. So I am an engineer, and so you can be sure that whatever I do has some technology involved. Before I start, I also want to thank CMMI and CMS for the opportunity to deploy our intervention. And looking at the statistics, I realized it was actually a little easier to get into medical school than to get this grant. So with that, I'm going to talk about our particular intervention, and taking a paraphrase out of The Graduate, I want you all to think about one word, and that one word is feet. And just keep that in mind as I talk about our program intervention. We are a California company, so we're one of the private enterprises, and we are developing an intervention in combination with Aloha Care, which is one of the major Medicaid providers in Hawaii. And we are focused on a population of patients who have diabetes, who have exhibiting evidence of neuropathy, which is a sign of microvascular complications of diabetes. So this is a population, in contrast to the front end of the disease, where it's mostly lifestyle driven. These are people who are sort of heading into the accelerated phase of disease where serious and life-threatening and life-changing complications are just around the corner. We're looking to get to people who are in trouble, but where it's not too late to do anything to help them. And hopefully we'll provide some degree of motivation that they like their feet, they'd like to keep their feet. Our intervention is going to be deployed across the islands of Hawaii, and if those of you who know Hawaii realize that once you get outside of Waikiki, it's actually a very rural and difficult to maneuver state. So the use of telehealth is actually pretty essential if you're going to reach out to people in their homes and keep them there. Our goal is really aligned with the triple aim, which is to reduce the overall complication rate of diabetes, in particular the incidence of foot ulcers, which are a very common and expensive complication of diabetes. We expect as a result of this to improve standard measures of diabetes control, hemoglobin A1C, etc. And we expect that if we can reduce the number of foot ulcers that people experience, that we can achieve a measurable reduction in costs of care. So you would say, well, exactly how are we going to do this? Well, as a technologist, I love technology, but no healthcare problem is solved in isolation. It really is a system of care, and every element along the continuum has to be addressed in order to deliver results. So in our case, we need to be able to screen the population of people with diabetes to identify those who have neuropathy or evidence of microvascular complications. We need to provide tools to monitor them at home in a way that's convenient for them and doesn't unduly restrict their daily workflow. We need to provide a way to alert in cases where there are biometric markers or symptom markers that might indicate somebody is getting into trouble. And then we need to provide some sort of intervention in order to avert what would otherwise be a serious complication. Looking at our program design, you can see that diabetes is like a funnel. As most of you know, there are 25 million Americans with diabetes. In the Medicare population, the prevalence is about 28%. So it's a huge issue and growing. Diabetes is an insidious disease and ultimately results in a chronic inflammatory state, which results in a series of complications, some of which relate to the larger blood vessels, heart disease, cerebrovascular disease. A lot of it is more insidious, relating to the microcirculation, things that relate to the eyes, the kidneys, and also the nerves. And that's the part of the disease that we're focused on. So our goal is really to implement a tertiary prevention program, tertiary prevention because we're focused on people with diabetes who already are exhibiting complications. And so we have a lifestyle component which will hopefully reduce the rate of progression of microvascular disease. But after a certain point, once somebody has developed significant microvascular complications, significant neuropathy to the point where their foot is numb, then they're at great risk of foot ulcers. And at that point, a prevention, a lifestyle program is really not going to return sensation to their feet. And you need to be a lot more focused and granular in helping them to prevent a foot ulcer, which is the leading cause in this country of non-traumatic amputation. So how does our program work? Well, we have a great partner in Aloha Care. So we're fortunate in that we have more or less real-time access to their claims and pharmacy data. So we have an unparalleled view of the entire population of Aloha Care. And so we know in the case of Aloha Care, there are 72,000 or so members in Hawaii who are Medicaid Quest members in Aloha Care. About 4,000 of them have diabetes according to the HEDIS criteria. Some fraction of those patients with diabetes will have evidence based on medical claims of having had a previous foot ulcer or an amputation. They're what I would call the easiest to find and the ones that are in most need of a foot ulcer prevention module, and we call them the phase 1. Phase 2 is the larger number of people who have neuropathy, some of whom may not know that they have a numb foot yet. And there is really the application for our first piece of technology. We'll be using a little device. The state of the art today for diagnosing diabetic neuropathy, for those of you who are clinicians in the audience, is essentially a piece of fishing line that you use to tap on the bottom of the foot. And if you feel it, you don't have neuropathy, clinically significant neuropathy. If you do feel it, you don't. And that to me is about as silly as telling somebody, well, you may have coronary artery disease, but we really won't know until you have chest pain. And so this device actually provides an objective way in about 20 or 30 seconds of testing a nerve in the lower extremity, the sural nerve, for evidence of abnormal nerve function, which is a way of objectively diagnosing or detecting neuropathy in this population. And what's interesting is that you can identify neuropathy before people have symptoms, which creates a very powerful opportunity for having a much more focused conversation with a patient about changing their lifestyle or reducing the risk of them going further and developing a foot ulcer. There's an interesting piece here which is not really a focus of our program, but for those of you doing Medicare risk adjustment, there is a real important component here about doing a proper risk adjustment of the population based on medical issues. One of the things that we can do is by identifying neuropathy, you can identify potentially a higher risk population. The other pieces that we'll be using are what I would call conventional mHealth technology, wireless glucose meters. I guess in walking around the booth, that's more or less the state of the art now. But I think that the heart of any diabetes intervention has to be about getting people to focus on their blood sugars and managing their blood sugars more effectively. We'll be using a wireless 3G tablet as our telehealth portal. And why are we using that? Because Samsung can do a heck of a better job of designing this kind of technology than I can, and at a lot lower cost. And this is a ubiquitous technology which can be easily replaced. And we'll be using primarily as a communication tool to be able to use the video conferencing capabilities built into these devices to communicate with the patient, to be able to send messages back and forth to the patient, to push content out to the patient, and to be able to provide internet connectivity to many people in Hawaii who would otherwise not have it but for this program. The last piece relates to a specific feature for the population, which is how do you tell if somebody's developing a foot ulcer if they don't know what to look for or they can't feel if they have a sore on the bottom of their feet? Well, the obvious answer is you take a picture. And you do it in a way that doesn't interfere with their workflow. And you basically develop a camera system that if you step on it, it takes a picture of your foot, it pumps using the same Android wireless tablet, sends the picture up to the cloud, and you can then look at these pictures on a daily basis to look for early changes that might indicate somebody is developing a foot ulcer. Now, I've talked a lot about technology, but I am also a physician, and I know that technology is worthless unless you have an engaged patient, and in many cases that takes much more than a caregiver. Like a physician, it takes a caregiver, like a care coordinator, which is really, I think, one of the emerging powerhouses of the new healthcare workforce. And we're engaging a series of care coordinators that we've hired who are actually form the backbone of our program and provide the bulk of the interaction with the patient, and also contact the patient in the event of either biometric data that's out of bounds, or an indication that the patient needs to be followed up for further evaluation of a potential problem with their feet. And with that, I'll stop here. There's a lot more to the program, but I thought I would just give a 10-minute high-level overview. Thank you.
Thank you, David. Now we're going to hear from Will Schrank. We've heard some interesting examples of the types of projects that are in the Innovation Awards, and how in the heck do we evaluate them? How do we look for cost effectiveness? How do we look for improvements in quality? And Will tell us about that.
So after hearing all these really interesting programs, I'm sure what you're most excited to hear about is how we're going to evaluate them. But the reality is the evaluation is really central to the success of these programs. We fund these programs with the hope that we can demonstrate that some either reduce costs and are quality neutral or better, or improve quality and are cost and are budget neutral. And those are the criteria we're looking for in order to ultimately make decisions about whether or not these programs can be expanded more broadly. And all of these folks want their programs expanded more broadly, and we want their programs expanded more broadly. And it's going to require a very close collaboration between us and them to work with them, to understand what the data is that's available, the specific measures and metrics we ought to be working on, to try to work as a team, a collaborative team, to get to a place where we can really accurately and rigorously assess whether or not it looks like these programs meet those criteria, and we can, in fact, continue these programs beyond the end of the model. So what I'm going to do now is talk kind of briefly about our general approach to rapid cycle evaluation, and then I'm going to move on and talk a little bit more specifically about this program, which has, it brings, which is a much more different environment than any of our other models that we're evaluating at the Innovation Center. So first of all, it's important to recognize that none of the models that we test, whether it's a Pioneer ACO, bundled hospitalizations, or some automated hovering intervention, none of these are turnkey interventions. It's, in every one of these cases, the folks who are running or leading these interventions, these organizations, are going to have to learn and evolve and grow and get better, and they're going to need data. They're going to need feedback, and they're going to need to be able to measure their performance against specific outcomes. There must be substantial learning and adaptation during the course in order for us to ultimately get to a place where we can really accurately detect whether or not it's the idea and the intervention rather than just the implementation of the intervention that's being measured and determined to be either a success or not something that we can expand. And the key principles that we bring to the table are, first, we want to be part of the solution. Historically, CMS has been criticized for evaluations that happen at the end of an intervention. So an intervention that happens for 4 or 5 years, we would measure at the end and say, well, it doesn't seem like it works. But is it the fact, was it that the intervention didn't work, or was it that it wasn't implemented ideally? So our goal is to be much more proactive, much more involved, much more collaborative, and during the course of all of our interventions, we're going to be rapidly and regularly providing feedback, real-time data to our providers in the field, to the programs in the field, to give them a sense about how they're doing, how they're progressing, what their progress looks like, so that they can manage to those outcomes. And the speed is really critical to us. Speed both in terms of getting data and feedback to our providers, but also we set the length of these tests often conservatively. Let's say we do a patient-centered medical home test. We set the length of the test at 5 years because we want to make sure we have enough time to be able to pick up a difference. But it may be that after a year and a half or 2 years, we have compelling evidence that we're saving money and improving quality, and if so, at a time where we have meaningful budgetary constraints and concerns, if we could come up with an answer that allows us to improve quality and reduce costs, we must identify it absolutely as fast as we can and implement it. And throughout all this, we have to maintain our rigor. So speed cannot be by trying to move faster, we must not sacrifice rigor. We're making important decisions about, large sums of taxpayer money, and we need to make sure that we are using the very best evidence on which to base these decisions. So there's two kind of key ways that we think about our evaluations. There's a formative piece, which I was getting at before, that we want to sort of regularly give feedback to providers. But part of it is also we need to understand the context. We need to understand what are the features of an intervention that may or may not be associated with success. We need to study their process, and these have to be important predictors so that as we measure performance, we can try to tease out what are the features of programs that seem to be successful, and we can therefore help create learning collaboratives with these programs to rapidly harvest and disseminate the most effective strategies. And we do that with a learning and diffusion team that creates learning collaboratives. In all of our models, we have learning collaboratives amongst the participants so that they learn from each other. And we use our learning and diffusion team to help identify sort of the key salient messages about what's working and what's not working so that we can spread those effective practices and policies as soon as we can. But again, in terms of our summative evaluation, our rigorous evaluation that's ultimately going to be the test that we're going to use to determine whether or not a program will be expanded, we need to have a high level of rigor, and that includes really thoughtful approach to sample selection, to our control group selection, to what data we're going to use, sample size. We're really, really thoughtful about using the right measures and trying to use similar measures across all programs. And we're moving towards more population-based measures and measures to assess equity and access to try to make sure we're capturing the key features that we want to address in these programs. And we're pushing our contractors who are helping evaluate these programs to use the most advanced epidemiologic or statistical methods to assess performance. But here, when it comes to the innovation awards, the game is a little bit different. We have a huge amount of heterogeneity. We have, the programs are very, very, very different. In some of the programs, accessing data is going to be far more challenging, and we're going to rely on the programs themselves to access a lot of the data for us. And there's going to be an increasing amount of qualitative information that we're collecting, and we're going to need to be a lot more nimble in how we conduct our evaluations, and we will rely heavily on the program teams, and there's going to be a great deal of collaboration with them in terms of the data that they collect and their own assessments of their performance. So a big part is going to be self-evaluation. We're going to require that they're regularly measuring their own quality and their own outcomes, and that they're tracking measures, and that they're managing to those measures to try to make sure that they're continually improving their performance. On the other hand, we will simultaneously be conducting an independent evaluation using our claims data, and we're going to be feeding some of the data that's being collected by the sites into our claims-based evaluation to try to make our evaluation as robust as possible. So the phase one of our evaluation, we had a design contractor to help us identify how to sort of clump these 107 awardees. There's really massive heterogeneity. They're addressing all kinds of different problems, and we want to figure out how to bring similar programs together so that we can create learning collaboratives, so we can identify standard measures across a group, and so that we can identify a smaller, more manageable evaluation for an evaluation team. And we'll break the evaluation up into a number of different clusters. Part of what we have to do is try to really identify what the key measures are for each of the clusters. Another is to really focus on technical assistance so that all of our participants can actively and aggressively participate in their own self-evaluation. There are some programs that come to the table with a great deal of evaluation experience and are ready. And there are others that do not. And for us, we have to really make sure that we level the playing field as much as we can so that everyone is collecting data, everyone has outcomes to sort of work towards, and everyone has the data that they need to ultimately be effective. And then once this design contractor ends, sometime around June of this coming year, We will identify a group of external contractors that will measure, assess, evaluate each of these clusters, similar clusters of innovation awards, of innovation awardees, and they're going to use both our claims data. They're going to use qualitative data gathered on the street, gathered from the field. They're going to use survey data to access information about patient experience, and they're going to use real on-the-ground data about quality of performance from the awardees themselves to try to build a story, with you to understand the extent to which these novel and innovative and really, really exciting programs actually could help us get to this sort of holy grail where we can improve quality and reduce costs. Thanks.
If you could stay here, and if our other speakers could come up, we have a few minutes for questions from the floor. If you do have a question, would you please use the microphone and identify yourself and your organization? Yes.
My name is George Bailey, and I'm proud to say, and I want to thank you guys, we're the innovation project for Montana. We're called the Frontier Medicine Better Health Partnership, and we're rapidly building the first coordinated care organization that's the total state of Montana, 1 million lives. And today was the first time I heard about some of my partner innovation groups, and it's really exciting what you're doing, and my question will be here in just a second. But Dr. Gilfillan, when he announced the awards and the people in the room that trying to understand innovation, he summed it up this way. He said, you guys are part of a revolution. We're moving from a system-centric delivery system to a patient-centered, and if the mHealth movement doesn't make it patient-centric, I don't know what will. When we move to a predictive and we're going to predict and we're going to prevent. And David, I want to talk to you about some of your innovation, because we could probably use it in our, as you start testing it in our program right away. We're moving from predict to prevent. The past, we've been diagnosed. I'm in a little hospital of 2 doctors, about 3,000 patients, and so we diagnose and we treat, and then we ship to Missoula, and we never see them back. And part of our project is to try to treat them closest to their home and in their home and all these devices. But I'm here at the mHealth conference, and I'll say it to anybody in the room. I've said it to everybody that's on the floor. We're a great test bed for you, because we do have a really good healthcare informatic group, iAdvantage, that's going to measure how we're moving the needle. I'd like to work with all 3 of you and the others. But my question to you, William and Mark, are you guys, as part of the evaluation, when we get done and we start seeing some of these success stories, are we going to be not only sharing them with the other innovators, but we should have rapid deployment of what's working?
So we do, in fact, have a learning and diffusion team that is armed and ready for this job. And in fact, maybe never before is their role as big as it is here. There are so many different things that are being tested, and we need to rapidly get the information out about what's working and what's not working. So this is going to be a really sort of high-speed, high-stakes effort to get information out. We don't want to sprint out and give information that isn't valid, and we want to make sure that we believe our evaluations before we start sharing information. We don't want to just sort of start saying that something works on the basis of some spurious, data from a single month. But when data is compelling, I think there will be no shortage of sharing of that information, definitely within the participants of the Innovation Awards. But our goal is to expand programs and to spread it beyond, and that's our highest priority.
The glow cap, if you think of frontier and rural America, what a better solution, if it's proving to be cost effective. So.
Thank you very much, George.
I appreciate that.
Gentleman from the back.
I'm Ray Sweiswitz. I'm an entrepreneur from Raleigh-Durham, North Carolina. I applaud CMS for the actions and the scientific method and the approach. It's fantastic. Question, have you been in discussion with other members of CMS in the hopeful scenario that your experiments prove to be favorable in terms of lowering costs? Is there any consideration to modifying policy so that some of these things can be paid for? Is that at all within the realm of possibility in our lifetimes?
Well, we certainly hope so. Well, if Will and his colleagues show that projects are both improving quality and reducing costs, those are winners for us, and we do hope to move the policy needle as well as the experimentation needle. And in the past, a number of projects, a number of innovations in what is now the Innovation Center and its predecessors have in fact become policies, including community access hospitals, DRGs, hospice care under Medicare program. There's a lot of projects that have been turned into policy, and that's the whole intent of this project. Yes, sir.
Actually, let me just add one thing. So one unique feature of the Innovation Center is that we have a unique statutory opportunity that if we are able to demonstrate that a model reduces costs and is quality neutral or better, we do not have to go through the lawmaking process. We can instead go through the rulemaking process internally and expand a program. For the Innovation Awards, these are small programs. We're not testing them nationally. None of them are generalizable, and none are going to be ready to be sort of immediately scaled nationally. But this is precisely one of the really neat things about our opportunity here is that if we are able to demonstrate and identify successful models, we do have the chance to spread them.
Thanks for adding
that. I'm sorry. I got here first. Hello, I'm Eric Brown from Molina Healthcare, and I had a question on the Affinity trial. I was curious, you talked during your presentation about the value of both automated data collection as well as manual input for like steps taken and things like that. Mm-hmm. And I don't know if children are any predictor of future results, but when you give them incentives, they often try to find ways to get those incentives, which so obviously lying is a good way to reach an incentive, and I'm wondering what you're doing in the study to deal with that and how you're hoping to account for that. Thank you.
Thank you. That's a really good question. We were early adopters of the pedometers with all the Bluetooth technology and loved them and thought they were really cool and people can't lie and aren't they fabulous and that kind of thing. They still lied on those. They put them on their dogs. They'd run them around with their kids and stuff like that to win the challenges. So there were ways that they got around that as well. However, what we did find and we did not expect is that, and we have not tested this yet with children, so I can't tell you with children yet. We've been primarily, for the last 2 years, all of our testing has been on the commercial side, in the work site, so in large employers, small employers, in the work site environment, so you're talking 18 to 65. But I will tell you this, that what we found, which was really interesting, is we would have one work site that would be using the low-cost pedometers because the employer only wanted to pay for the low-cost pedometers, and others that were using the Coolorama Bluetooth pedometers. And what we found interesting is that the people that were actually using the low-cost pedometers and entering their steps in themselves into the website or into the mobile device were actually able to see other content and resources we had, and they were spending 2 to 4 minutes. They were also chatting online. They were using our Twitter stuff. They were chatting to each other on the Teams, and so their engagement actually went up. Now, whether or not they were cheating and lying around to, do the steps, we don't have an ability to tell that right now. But I can tell you that we were getting 2 to 4 minutes on an average, depending on the demographic and the size of the company, extra engagement by having them actually enter into their data into the either mobile technology or the website. So there's pros and cons of both, and we're going to watch that really carefully and monitor that. Thank you.
Anybody else? Miss?
Hi, I'm Stacy Lindau. I'm from the University of Chicago, and we have one of the Healthcare Innovation Awards for a project called Community RX. So I've emailed with some of you, and I'm really interested. This award has been interesting from the perspective of being in an academic medical center and being traditionally a grant-funded investigator. I'm wondering to what degree the fact of the Innovation Awards has affected any cultural changes inside CMS? I mean, how is this different for you from the kind of ways you typically interact with investigators? And a separate question, but it's related to how it's different for us from grant work, is how are you thinking about intellectual property issues? Does the government intend to claim ownership to any of the intellectual property developed through these projects? I imagine for people who work for not-for-profit companies or organizations, you're more accustomed to these issues than we are under the award. So thank you.
Well, can we first ask you how you think it's different for you working with us as compared to working with NIH?
Well, it is culturally different. So, I really think that what we propose to you is a business plan as opposed to a grant. There are similarities in terms of having reasonable hypotheses that are based upon evidence and a plan for evaluating those. But the piece around a business plan per beneficiary per year calculations and projecting those out is just something I'd never had to do before in writing a research grant for NIH. So thinking about the work as what's the return on investment for the work and what's the sustainability and scalability for the work are important, really good questions, and in fact probably would improve my grant writing down the road for NIH, but not a way that I had really had to think before. So that's one thing that's different. The other is this is a cooperative agreement, so it's been quite interesting to interact with our project officer around development of the work. And typically, we're not in a position with NIH where we're relying on them for data that would be important for evaluating our key hypotheses. So here's a case where we're really dependent on our partners in the federal government for critical data, claims data, et cetera. And so we have to figure out how to get it from you quickly to evaluate ourselves. That's another area that's different from my grant-funded work. And I would say the intellectual property issue is kind of a question mark.
Yeah, and I'm going to, on the second part, the intellectual property, there are actually defined statements on that. I'm not a lawyer. I'm not going to try to define and state all that except to say that, yes, intellectual property that's developed by an organization is retained by the organization, but the government has rights to use it on a reasonable basis. And other than that, I'll refer you to your own terms and conditions that include some of those details. In terms of the question about how this is different from CMS, yeah, it's a lot different for CMS in a number of ways. First of all, the scale. Used to be in the old demonstrations group in HICFA, going back to the old days. Our budgets there were on the order of $20 to $30 million a year. Now this one project has $900 million, and there are a number of other projects that are fairly sizable too. So in scope, it's hugely different. Secondly, these are self-designed projects. We would typically, in the old days, go out with a very narrowly defined, you will do this, 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 and this, and we will do it at 5 sites around the country, and we'll see how it works. And we're going to have control groups and so forth. So in many ways, that was easier to evaluate. We'd have really much better control and evaluation, rigorous, but it had the huge cost of really not encouraging the same level of innovation and number of different ideas around the country. Thirdly, as Will pointed out, and you'll want to talk about the evaluation, it's going to be quite a bit different. And finally, as you mentioned, it's a cooperative agreement. There's a lot of interaction with the project officer. We don't just hand over a bunch of money and say, we'll see you in 3 years. Did you want to add to that?
Yeah, just a little bit. So I totally agree with you, what Mark said, but I think the big difference is we see this as a partnership. And it's good for us for this to be a partnership because we need to be giving you what you need to succeed. Whether it's data, whether it's input from other participants, whether it's our job. It's in our best interest for you to win. It's also in your best interest for our partnership to work. Because if our partnership works, we're the home for what you're creating. So this is a symbiotic relationship as you can possibly make. We call it a cooperative agreement, but it's really a it's not a grant. We're not just giving you money for you to go do your own thing. If we did, I don't think it would work as well. I don't think you'd be as likely to create a product that ultimately we could use and that the American people could benefit from. So I think this is, I think there's something beautiful about how we're interacting and trying to support and enhance and encourage and sort of develop together strategies for improvement.
Are there any other questions? Does the panel have anything they want to add? Kevin? I had a chance.
I feel like I should say something. Well, I agree with what Will said. I think it's, it's interesting because most of our government-funded work has been from NIH, so we're very used to the grant-funded model where somebody gives us money and we do our thing and then report back to them periodically and everyone seems happy. But I do think that this is much more like the type of arrangements we've had with various private industry partners where they have been much more involved and for a lot of the same reasons where we're trying to build something that can actually be used on a wide scale, and so having the back and forth and the interaction I think could be a very important ingredient to making that successful.
Can I say something? I think it's weird. I think that we're a for-profit company, one of the strange little for-profit companies, and we're not used to any kind of interaction. We're entrepreneurial, we do our own thing, and we do it the way that we want to do it. But what's really resulted with this cooperative agreement is some really amazing things, which I've been really excited about. One is that at first it was hard to get used to have all of the little things in place and all the little things that we had to report to. But once we adapted and said, let's just make those criteria part of the measurement data that we're collecting, it changed the nature of the intervention itself. And so we started thinking about all the measurement in advance, and it's been incredibly helpful. We've also already engaged with 2 other states and with their payers because of this that we're working with right now as a direct result of this. So now we're working with the state of Oregon on the same kind of program that we modeled over here. And so it's been incredibly useful, even though at first it was hard to get used to. Does that?
Right. David?
Well, I'm also from the private enterprise side, and until this grant, my only interaction with the government has been going to DMV. And I would have to say that I had no expectations because I've never received a federal grant in my career. And so I didn't know what to expect, and I have to say that if this is the kind of work that's coming out of our government, I think that I'm very bullish on where healthcare is going to be going over the next 10 or 15 years.
Well, thanks for those comments. Thanks very much to the audience for participating and attending, and a special thanks, very hearty thanks to our panel for their presentations and your contributions this afternoon. Thank you very much.